Good evening. I'm Dr. Allan Perel, and this is Conversation in Medicine. This program brings cutting-edge topics to the Staten Island and tri-state community. Tonight's topic is osteoporosis, bone thinning. This goes from anywhere from our thoughts about usually women who are hunched over, people who are getting fractures by trivial falls, and where have we come in all these years in order to fight osteoporosis? So I have a wonderful guest here, Dr. Philip Otterbeck, Chairman of the Department of Internal Medicine at Richmond University Medical Center and Chief of the Division of Endocrinology. That's a mouthful. He basically does everything in the hospital, keeps us all on our toes, and it's an absolute pleasure to have you here, my friend. So we're going to talk about osteoporosis and where we've come. This is, especially if we don't know about, if someone doesn't know they have osteoporosis, this is a scary thing. In medical school days, they always talk about usually a woman who, postmenopausal, after they went through menopause, them breaking their hip with a trivial amount of trauma. They stub your toe and you could break your hip. And they didn't realize that the bones were thin. And we sometimes see patients who can't walk, who can't stand up straight. Where are we in this year, in this age, with regard to osteoporosis, and what is osteoporosis?
So, if we start off with the word osteoporosis, osteo, of course, meaning bone, and porosis, porous bones. So, so really the word basically tells it all. And what it means is there is a decrease in the bone density. Density, of course, is mass per unit volume. So for every bit of volume that we have decreased mass in somebody with osteoporosis. And in addition to the bone density being low, we have poor bone quality. Now, how often do we see this? What are the numbers in the United States or the world? If we think about the United States specifically, we've got 8 million women in the United States with osteoporosis, and
wow.
and 2 million men. So this is a very common disease, and not only is it important to think about osteoporosis, but what are the consequences of osteoporosis, and that is the fractures that you talked about.
So let's go over some definitions. Actually,
Yep.
Who takes care of osteoporosis? Sometimes we use this as a question for all of my guests. You know, as a neurologist, I see certain patients. As a primary care physician, people take care of certain patients. As an endocrinologist, an internist, you see certain patients. Who takes care of someone with osteoporosis? Who diagnoses this?
This is a great question, and it is a disease state that's really shared by a variety of different specialties. I always talk about the primary care provider being kind of the gatekeeper of everything. Those are the folks that are making most of the diagnoses. That is the family practitioner, the internal medicine doctor, the physician assistants and nurse practitioners that are practicing that primary care. But for many women, they don't see a primary care doctor or a traditional primary care doctor as we think about it, a family practice or an internist. They're seeing their gynecologist. And so many times the gynecologist is the first one to order and detect and screen for osteoporosis. And then there are the specialists. And between specialists, endocrinologists, my field, and rheumatologists also have taken this disease state as their own. So really it is an interplay between all of these folks that diagnose and treat osteoporosis. And then, of course, our colleagues in the orthopedic community, they deal with the consequences of bone breaking and bone fractures, doing things like hip replacements and pinning and all of these different procedures that they do to treat it once it's been once the people have suffered the consequence of osteoporosis.
So let's go over definitions again. Osteoporosis you talked about. We sometimes hear the word osteopenia. What does that mean?
So there's basically 3 categories that I would like the audience to think about. One is normal, one is osteopenia, and one is osteoporosis. Osteoporosis is the more severe bone disease. Osteopenia is kind of in the middle, and normal is normal. So why is there a distinction? Why is it important to make a distinction? Where are those distinctions made? Well, what we use is, to make the definition of osteoporosis, we use something called the standard deviation. And when you're more than 2 standard deviations from a normal, young, healthy person, 2.5 standard deviations. That means you have osteoporosis. So what does that mean to a patient? Well, they go visit their doctor, they get their bone density checked. And
how do they get it checked?
So they would go to a radiology center, and they would go, and it's what's called a DEXA scan, and the doctor would write the prescription for DEXA scan. And what they do is they look at various parts of the skeleton. They look at the spine, and they look at the hip, and as part of that, they're looking as well at the femur, and they're telling us how this patient's bone health is by looking at the bone density that we discussed a little while ago.
So for our viewers, just even jump right in, when do you get this? I mean, 18-year-olds don't get this usually. So
That's correct.
what are the recommendations? So people are thinking to themselves, do I need to have it done? While people are sitting here watching TV and sitting on their couch, and we'll talk about exercise, how important that is in a few moments, when do you get it?
So believe it or not, it's a bit of a controversial question, but here are the basics. If you're a postmenopausal woman at age 65, you should get it. If you are a younger woman, 60, 55, whatever, and you have a condition that exposes you to a higher risk for osteoporosis, that is, you have a problem with your parathyroid gland, hyperparathyroidism, or you have a lung problem, asthma, and the doctor puts you on a long course of steroids for permanent steroids, those are people that should have the test a lot earlier. But the general thing to remember is age 65, menopausal woman, you should get it. I alluded to the fact that a few minutes ago that there are 2 million men in the United States that have osteoporosis. When should men be checked? And that is a very controversial question because some organizations don't recommend screening men, and some recommend screening men at the age of 70. So along with your doctor, if you're a man and you're in that group, you should have that conversation. Doctor, do you think I should be screened or not? You bring your preference to the physician, and that physician will give you their preferences, and then you come to an approach that works for you.
So that test will tell you whether you're normal, osteopenia, which is like a little bit of bone issues, or osteoporosis, which is very concerning.
Correct.
Do people go back and forth, meaning at different times, and we'll talk about treatments in a little bit, can someone who has osteoporosis have less osteoporosis, become osteopenic, or osteopenia, either way?
So the answer is you don't go back and forth. Once you've got it, you've got it. And you've got it when you've got that T-score. So you get the report from the doctor, you have it, and it says your T-score is when it's less than -2.5. So say it's -3. That's diagnostic of osteoporosis. Now, there are a few things that we would recommend for that patient, a few medications that we'd recommend. That might improve the patient to what we would traditionally think is the osteopenia range. So say it moved it from -3 to -2.2. We don't say that that patient now has osteopenia. We say that the patient has well-treated and improving osteoporosis. So it's important, though, when we think about whom we're going to treat, we don't only treat the people with osteoporosis. And why is that important? Because half of the bone fractures occur in people that have osteoporosis, and half of them occur in people that have what we would say is osteopenia range. So then you might ask me, well, do we treat everybody in osteopenia range? The answer is no. How do we figure out who we want to treat? And I know we're going to get to the actual treatments in a few minutes, but how do we know who we're going to treat? Well, we look at particular factors. What is the age of the patient? What is the bone density? What's their family history? Have they been on steroids? And we put that into a calculator called a FRAX, F-R-A-X. And everybody can look at that at www.frax.com. And they can put in their risk factors for developing a fracture. And when you put in those risks, at the end of it, the end of the calculation, you hit calculate, it tells you your risk for a major osteoporotic fracture or the risk for a hip fracture. If your risk for a hip fracture exceeds 3%, we treat. If the risk for major osteoporotic fracture exceeds 20%, we treat. And so even in the osteopenia range, we're treating those patients when they have those higher risks.
So FRAC stands for fracture.
That's right.
So it's an interesting name to put that in. And you said you can go online and just put FRAX and this will pop up.
Correct.
You can put your own risk factors there.
Yeah.
But of course the key is this DEXA scan to add that there, because that you can't do by yourself at home.
Correct. You would need that piece of information to put into that calculator to make the assessment.
So let's assume someone has osteoporosis or osteopenia that needs to be treated.
Yes.
How do we treat them?
So it's a multimodal approach, I would say. There is the diet and exercise component to it. There's a risk factor modification component to it. And of course, there are medications. So one of the first things that people need to do is to, if they're smoking, stop smoking. Smoking is directly toxic to the bone.
So nothing, not that cardiovascular health, neurological health, blood vessel health, this is totally different. It's not related to those things.
That's right. And the smoking, of course, will give us heart attacks and strokes and all those things. But this is an additional reason not to smoke. It's a direct toxic effect to bone. The other thing is alcohol, excessive alcohol consumption. People that struggle with alcoholism, those people have a strong tendency, because alcohol itself is also toxic to bone. And also people that struggle with these illnesses, alcoholism and such, many times don't get the best nutrients. And it is important for us, bone is mostly made of what? Calcium. And if we don't get enough calcium in our diet, we'll have an increased risk for fracture because calcium literally is the building block of bone. So we recommend for patients with osteoporosis, they need to take 1,200 milligrams of calcium per day. Whether they get that from a supplement or from their diet, it should add up to 1,200 milligrams.
How do you know in your diet you're getting 1,200 milligrams?
So it is not easy to figure out, right? I mean, of course, all the containers for food do list some of these things, but of course, when you go to a restaurant, they don't list all of these particular minerals that you're going to be getting from the food. So that's why, generally speaking, we recommend that people get the calcium that they need from calcium supplementation.
How about vitamin D? That's been a hot topic. People want to go in the sun, literally hot. Vitamin D has gone in and out of favor as being something that we should be very concerned about, especially in neurological topics. I mean, there are diseases like MS where people who live close to the equator have a low incidence of it, and I think they're protected because of vitamin D, and people farther away are not. So here, especially since we're not that close to the equator, which we notice this time of year, it's cold out, the idea about vitamin D and osteoporosis and bone health as a whole, what do you think of it?
Vitamin D is very important for bone health. As you point out, vitamin D has been touted as sort of the panacea for all things great. But as time has passed, the evidence-based medicine really has not demonstrated that convincingly. Nevertheless, vitamin D is indeed quite important for bone health. And the recommendation for those with osteoporosis is for them to take at least 800 international units of vitamin D per day. But it's a little misleading because vitamin D really, to optimize the level, you need to check the level. And we check the level by checking the blood test. And for those that have vitamin D sufficiency, that would be consistent with a level greater than 30. And so that's where we really should try to get for those with osteoporosis. Easily checked on a blood test.
Does higher levels help? I mean, a lot of my patients, we talk about it that the levels are between 30 and 100, difference in different labs.
Yeah.
So if someone has a level of 32, a lot of times, even in my practice, we'll try to get them, because of their various neurological issues, trying to get them to the middle of that range rather than the lower portion. How about with regard to bone health?
So the best evidence that we have is 30 and above. Right. There was some controversy as to whether or not the level of 20 was enough for optimal bone health, but more and more data is being accumulated over the past few years with 30 really is the number where we want to be. We have no objection to being at 50 or 70, but of course, as they get closer to 100, we get a little bit nervous because they can develop vitamin D toxicity. Of course, in the literature and in popular culture, we do see, the concept that some patients will read about vitamin D, and the idea of if a little bit of vitamin D is good, a lot must be even better. While that might work for some things, it doesn't work for vitamin D, because if it exceeds 100, that can result in a high blood calcium, which can be dangerous. So long as you keep it below 100, very few people are going to get into trouble that way.
So that's calcium and vitamin D. Now, what else do we do?
Well, so in addition to calcium and vitamin D, there's physical activity. There's very good evidence that that cardiovascular exercise, and especially weight-bearing exercise, is good for individuals with osteoporosis. And they can do this weight-bearing exercise 30 minutes a day, 5-6 days a week. And if that's done, it has a very significant decreased risk for bone fracture, and improvement, and with concomitant increases in bone density.
If we have our people talking to our viewers, what's weight-bearing? Is walking weight-bearing? Do you have to use weights to be weight-bearing? So what would, if someone's home right now and said, I want to get started doing this?
Yes.
What would you tell them to do?
Well, weight-bearing generally is anything that, well, using weights is a good example of a weight-bearing exercise, right? Because you are using weights against and pushing against something. And I would say that that is particularly good for people with osteoporosis for a few reasons. Because we're not only worried about improving the bone density, although that's very important, but as I'm sure in your practice, you're asking people to improve their muscle strength, not only for their bone density, but so that they don't fall.
Right.
And when you don't fall as much, you're not going to break your bones as much. So anything that does weight training really is a good thing to do. But yes, walking, an elliptical, running, if patients can run, those things are also efficacious with respect to improving your bone density.
So the scariest thing that really leads to people not doing well is falling.
Yes.
So if there's anything we could do to have people not fall, break bones, hit your head, all the things that we're worried about, if there's one thing that we can convey, just be careful. You know, if you have to use an assistive device or someone help you, make your house friendly, not have throw rugs and things like that. Falling is a major issue. We probably should have an entire show on how to avoid falling. But just jumping ahead, so we talked about those things. Now we're going to get into some of the medications, and where are we in this era than we were compared to where we were before, and possibly has that changed how we have less fractures, less people with, and I always remember as a kid the word Dowager's hump, in women who almost like they're bent over and they couldn't straighten up. I don't know where that word came from, but just the idea of what happened, and we don't see it as often. But what could we do if someone is diagnosed with having osteoporosis in a timely fashion to prevent fractures, but also just stand up straight?
Yeah. I remember as a kid, you know, I had a family member that was, as you described, all hunched over, and I just always wondered as a child how it wound up that she was like that, and now, of course, you know, learning about osteoporosis, I understand it much more. And it's sad because had she had the access to the medications that we have today, likely she would not have gotten to that position. There are two main types of osteoporosis medicines that we have. The ones that have traditionally been used are what we would call the anti-resorptive drugs, and these newer, pretty exciting drugs are what we call the anabolic drugs. And let's try to dig into that just a little bit. If we think about bone, there are two main kinds of cells that are involved in the interplay, the bone breakdown and the bone formation. The audience might know that healthy bone is formed by what we call the osteoblasts. Those are cells that build bone, B for build, right? Osteoblasts build the bone, and osteoclasts, which are the other types of cells, break down that bone. And it's the interplay between those two cells that really make healthy bone. You break down the bad bone and you build the healthy bone. Now, the drugs that we've usually had, traditionally had, the anti-resorptive drugs, they come in two basic flavors, the bisphosphonates, and another drug called denosumab. We'll go into that in a little bit. But basically, they work by inhibiting the work of the osteoclasts, the bone breakers. So when inhibiting those bone breakers, you're allowing the bone builders to do more of what it is that they need to do. And those types of medicines have traditionally been known as drugs like Fosamax or Actonel. These are pills that have been taken either once a week or once a month to improve the bone density. And then there's another injection called Prolia or denosumab. It's a once every 6-month injection that is an anti-resorptive drug that is very efficacious at preventing those fractures and improvements in bone density.
Right. So that's to prevent the breakdown.
Right.
Now, what else? What's the newer things coming out?
Right. So that's actually where we start, though, because those are the traditional drugs. Those are the ones that have the real decades of research and safety behind them. So most of the time, if one of the patients is diagnosed with osteoporosis, that's really where the doctor is going to go first.
Could we arrest this disorder with those therapies? Meaning, again, there are a lot of diseases that continue even afterwards. People with high cholesterol level, we get their cholesterol lower, but some of the implications, things still happen because of that. Patients who have diabetes, they will still sometimes have residual problems, even if we get their sugar down. Have we gotten at all to a point where if we give these medicines that prevent the breakdown and calcium supplementation, that we could stop the process or close to stop it?
We can slow it down, and we can decrease the risk for fracture. So, whenever you look at these studies, they always talk about what they call a relative risk reduction, meaning the bones are deteriorating with age or patients' medical problems, and these medicines will slow that progression. One of the things the audience should realize that we achieve our peak bone mass at age 30. And like many things after age 30, everything goes downhill. So peak bone mass is at 30, and our bones start to break down to 30, and they do so over the course of our lives. So these medicines will slow that breakdown and hopefully slightly improve the bone density. But it will not prevent all fractures, but it will prevent and stop a lot of them. And that's what is important for our patients.
So tell us about new treatments. So basically, that's what we talked about, standard therapies. Tell us some exciting new things, especially people who might have gone to their physician and at the doctor's office they said, you have it, we've given you the medicines, and maybe they had a fracture, maybe they had a fall, and they say, what do I do now?
Right. So there are newer agents, we call them anabolic agents, and there are 3 of them. The trade names, the chemical names are very long. I'll give you the trade names, which the audience will understand and recall. Evenity is one, Forteo, and Tymlos, so the 3 anabolic agents. And these are injectable medicines. So the Forteo and the Tymlos are once daily injections, and the Evenity is a once every month infusion. And these medicines are less about preventing the work of the osteoclasts, the bone breakers, but they're more about stimulating the work of the osteoblasts, the bone builders. And they are quite effective at doing that. And they have pretty dramatic improvements in the bone density for patients. However, these are newer agents, and the long term of these drugs we don't know, and their long-term effect on the stability of the bones is unknown. So if we're going to use these drugs, we usually reserve them for individuals that have severely low bone density, or individuals that have been on the traditional therapy and have failed. That is, they fractured despite being on that therapy. And then we say, okay, well, we've tried this, we've tried the traditional stuff, let's try something a little bit different, a little bit newer. And that's where these anabolic agents would fit in.
So many of our patients have undergone various treatments for fibroids, or had early menopause, and whether if their ovaries were taken out. You were talking about, could you give us the relationship between bone health and sex hormones such as estrogen?
Yes. Estrogen is very important for bone health. There's a variety of reasons for that, and a lot of it centers around this interplay between the osteoblast and the osteoclast. When you lose your estrogen, the osteoclasts have more of a dominance and break down the bone more, and don't let the bone builders, the osteoblasts, do their thing. So estrogen is very important. And it's one of the reasons why, especially in a young woman, I get very concerned when people say, oh, well, my period is off. And then I'll say, well, why is the period off? And there are a variety of reasons for that. Sometimes it's stress. Sometimes there's other conditions like polycystic ovary syndrome. There are a variety of reasons for a woman's period to be off. But without exception, it's not okay that that period is off. And why? Because that reflects the fact that they're not getting the required amount of estrogen to make their bones as healthy as they can be. And if they don't correct that, even in their teens or their 20s, what's going to happen is by the time they're 30, if their peak bone mass was supposed to be up here, they're only going to get over here, and they're going to start off a lot lower. So while they look fine and they're young and healthy at age 30, despite the fact that they have their regular menstrual cycles, by age 50 or 60, their bones are going to be in a lot worse position than they would have been had they had a normal menstrual cycle.
Compared to everyone else.
That's right.
Very interesting.
Yeah.
So what about people who've had early menopause? Would those patients be people we would get a DEXA scan on earlier? Would those patients we'd be more aggressive with treatment?
Yes. Well, yes is the answer. And even before we get to the osteoporosis, those people that have the premature menopause, they should be considered for other therapies that would prevent the osteoporosis. Specifically, that would be hormonal therapies or birth control pills, so that they would not, despite the fact that their ovaries are not functioning. In endocrinology, we have something called premature ovarian failure. Women in their 30s that due to an autoimmune process, their ovaries turn off. And again, that's not okay because their bones will deteriorate at a much faster rate because of that lack of estrogen. Those people should be treated with hormonal therapy, specifically things like birth control pills, so that you protect their bones. And exactly to your question, Allan, they should have their DEXA scans a lot earlier than age 65, probably in their 40s or even at latest their 50s, because they're going to have deterioration in their bones much faster than the average person.
Thank you. Thank you so much. And we're going to talk about this in our last few seconds. I think the comment that we had that you told me earlier was that bone is living tissue.
Yes.
So many of us think about bone as just bone. It's almost like one of the legs of this chair or table, but it's not. It changes. So even though the bone looks the same, it comes and goes. They're remodeling. They're doing different things. So tell us about how is a living tissue you think about bone?
No, it's actually a great point, and we do think of bone as just kind of something that's hard that really is not changing at all. And nothing could be further from the truth. That bone is changing all the time through the work of those cells that we discussed, breaking it down, remodeling it, making new bone. And that's why it's so important to have enough calcium in the diet so that those cells can do their work, right? If you don't have the building blocks of bone, you can't build the bone. And that's why it's important to optimize your calcium indeed, to have those building blocks so that the cells can do that living tissue, that bone can be optimized to achieve the healthiest bone that we can have.
So I want to say thank you so much, Dr. Otterbeck. It's been a pleasure. It's again like being at Grand Rounds at Richmond University Medical Center. We learned so much from you. A lot to talk about bones and bone health. Let's not fall, and let's have our bones in the best shape we possibly can. Good night, everyone.